Okay, good morning. We'll go ahead and get started today. Thank you all for attending our pediatric grand rounds here at Phoenix Children's. Appreciate those who have joined online and attended here in person. I'm Ashish Patel. I'm a pediatric gastroenterologist and the physician-in-chief, and so it's a real honor for me today to introduce the team, really an emphasis on team because I know how important that is to Dr. Williams. The team to present today on pediatric feeding disorders. This team is really led by Dr. Donna Williams, who I had the real pleasure of meeting and working with when I first came here in 2020. Dr. Williams leads what I would consider the flagship program for our GI practice. It is the most well-established, multidisciplinary, research-focused, education-focused, and national reputation program that we have in gastroenterology. Dr. Williams' career as a clinician and educator and researcher is also highlighted by numerous awards and recognitions from learners at all levels, her co-faculty, her partners, and nationally. She's presented widely on this topic, and we've actually had junior faculty come here to Phoenix Children's to learn how she runs this program and how they should imitate the highest form of flattery, this program at their respective institutions. Additionally, it's a real honor for me to also introduce her partners today. Dr. Rosie Hodges is a clinical psychologist who I was fortunate to recruit out of her fellowship when she finished that in Dallas, and recruited her to be one of our first GI psychologists, and she still holds that title, obviously. And she's been great. She's really helped us develop many of our GI programs, including the aerodigestive and feeding disorder, where her passion really lies, but has helped with everything from abdominal pain to short bowel. So it's a real honor for her to be part of this program. And Stefanie Lauderdale, who is our licensed speech language pathologist. Thank you for being part of this. Again, as you see, this type of program really requires a comprehensive multidisciplinary approach. Stefanie has worked in this program and continues to develop the program's other multidisciplinary programs, but really focusing on not only the speech pathology, but really counseling and mentoring others in leading programs like this. So it's a real honor. I'll turn it over to them. Welcome.
Good morning, everyone. Thank you, Dr. Patel. It's an honor to be here today. Thank you, Dr. Hartley and the CME office for inviting us to speak on pediatric feeding disorder. I just wanted to say that hopefully some of you will be inspired by the work, but really the point of this is about the team. So the only disclosure today is that you need an iPhone. However, I do not speak for Apple or Verizon or any of those things because we want your thoughts and we want your participation. So as you're coming in for early grand rounds, why don't we learn about what you are hoping to learn this morning? And our GI fellows know this drill very, very well. So please go ahead and tell us. We could have asked a question about how many of you knew the topic before you got here. I was trying to be nice. Love it. Something new and patient-oriented. What is PFD, pediatric feeding disorder? You will hear us talk about PFD all day today, and really it stands for pediatric feeding disorder. What's new with PFD? How can we better care for our kiddos and families? What are some diagnostic criteria? Lovely. I think we are going to meet your learning goals, so stay tuned. those are our objectives. And really, we're going to go over a lot of material, but really to emphasize how much has been accomplished in the last couple of years in this field. We're going to talk a little bit about history, framework of the definition, prevalence, impact, screening and treatment strategies, high level, as they may give you an idea of what the next step might be for your patients. We're going to highlight some interesting research, including from our group, and we're going to discuss the specific importance of the psychosocial domain, some things that the pediatricians in the community can actually use prior to referring to our team. And then we're going to go into detail a little bit about the teamwork and the programs that we have here at Phoenix Children's, though that is just the tip of the iceberg in this type of work. So phones again, please. And let's just find out who our audience is. A lot of learners, which is what I see from the podium as well. PCPs, hospital medicine, subspecialty peds. Come on, surgeons. Okay, awesome. Because really we hope to inspire the new generation of pediatricians. So thank you for coming. So to emphasize the work in PFD, we're going to start with a very straightforward common case. We have a 3-month-old infant and who is brought to your office for some non-specific complaints of chronic congestion. Weight gain is not that great, little interest in feeding, back arching, no history of gagging, choking, and had some 2 mild respiratory illnesses since birth, but there were no hospitalizations. So I want you to think about your priority for this child's next step in management. Poor weight gain, some feeding refusal and back arching, some congestion, no other major aerodigestive symptoms like we would consider the choking, chronic cough, those kind of things, and 2 mild URIs. All right, I see some nice trends. People are thinking about families' goals. Others are intentional about obstacles to feeding. Watch the baby feed in the office, excellent strategy. And maybe thinking about development a little bit. And again, optimizing calorie intake for this patient. How many of you would like to treat for gastroesophageal reflux? Raise your hand, don't be afraid. Just treat for gastroesophageal reflux. Okay, all right, some of us are interested in that possibility. What I really like about our audience is that we're not jumping into its reflux. Now, Mark Gerber is going to kill me for this, but he and I argue about this a lot. And there's a good reason. There is a lot of interest in gastroesophageal reflux and aggressive treatment in babies like this. And we're not saying it's not reflux. We're saying there's probably a lot of things going on. So this baby has a is there a
Start the video.
Mm-hmm.
Drag the mouse over to the.
There is no mouse. Oh, of course there's a mouse.
Yeah.
Okay. Okay, so what you're seeing here is a video fluoroscopic swallow study. And on your last, you can see the contrast being ingested, kind of hanging out in the oropharynx here. And you can see a little bit of contrast here, kind of entering.
Mouse over, if you want them, the audience just can move your mouse over.
Oh. Okay, so you can see here the leftover and the penetration into the airway that happens at the time of the video fluoroscopic study. This is also the previously is a test that we also call modified barium swallow or MBS, but the newer nomenclature is VFSS. So what this case is emphasizing is a very common problem that presents with pediatric feeding disorder or feeding difficulties in infants. And we're going to dig a little bit into that because it has relevance to the first line of what we see either in the office or in patient care. So infants that have chronic respiratory symptoms, but not necessarily more commonly feeding problems, like our patient before, prolonged feedings, poor weight gain, and that little bit of aversion. There's something happening that is making the child uncomfortable and not want to eat. And also the physiology behind this kind of matches up to the clinical picture because there is immaturity in that swallowing mechanism in the first 6 months of life. So you could, in the, cough mechanism, so you could potentially aspirate and be silent. So the big teaching point is in this patient population, many times you have silent aspiration. And it really presents in this study with feeding issues more than any other symptoms, including respiratory. And this data was replicated by a cohort done by one of our medical students from U of A, published in revisions right now, and the same findings. There's a prevalence of feeding problems for the presentation of dysphagia and silent aspiration. Silent aspiration is going to be difficult to diagnose by clinical exam alone. So the speech and language pathologists in this room will know that they may take a look at the patient. There's a lot they can offer, but the video fluoroscopy is going to be much more reliable for diagnosis. And this study from Boston Children's shows just that. The sensitivity of the clinical evaluation in those kids that present with feeding difficulties is only 40%, meaning that if you are not going to get a modified barium swallow or a VFSS, you're going to miss the opportunity to realize that that patient has dysphagia. This was a young cohort, and the majority of patients were less than 6 months, but they went up to 9 months, and that is still the case. So the other thing that this study is noted is the high incidence of silent aspiration in those patients. So back to our case. 3 months old, poor weight gain, little interest in feeding. Okay, it's pulling up the old information. No problem. Are you guys still correct? So this is the pre, okay? Those were your objectives for treatment prior to reviewing the data that we just reviewed. So looking at those, do you guys feel that you still have the same next steps in your management, or do you think that might have changed? If you have some new next steps, please log them in.
There's not an active photo. No, response, yes, okay.
Okay, so I think some people are putting in imaging and the VFSS as the next step. Thank you. So we learned something together. All right. So what are once you come across those babies in your office, so what? What do we have to think about? Well, there's quite a bit of comorbidities that can be associated with dysphagia, silent or non-silent aspiration. And just have them in the back of your mind. We don't have to send the patient to an aerodigestive center yet. We don't have to do all the testing in the world. There's a lot we can do for treatment, which we're going to review in a minute, but there are those other comorbidities that you have to consider, particularly if the problem is persistent. And what we mean by persistent is 6 months and up. Vocal cords, laryngomalacia, laryngeal clefts, which are defects in the top of the airway, congenital heart disease can present with feeding difficulties and some degree of dysphagia, intrauterine drug exposure, and development in general should be on your radar. One little area of interest to consider is, what do we do with the kids that aspirate everything, all the consistency on the VFSS, right? So how many of you would think that that's a patient that needs tube placement and significant limitation of their oral intake to prevent complications of aspiration? Raise of hands. You guys are not worried about pulmonary? Okay. You can vote. What is your gut feeling? All right. That is a normal response to wonder about. So what you will see, and that's where we need to escalate. If that is a thought and a consideration and a concern, that's where we need to escalate the care that we provide, potentially to the level of the team. So the point of this slide to this, to what we were talking about, is that if you maintain as much oral intake in patients that are aspirating everything, you are going to have less hospitalizations long-term than if you don't, which makes a little bit of sense because you're practicing treatment for dysphagia, and potentially that will result in less complications, like significant complications such as pneumonia. Again, Boston Children's. All right, Paul Tran would laugh and put me on TikTok about this slide. All right, and he's right, but I'm right also, which means that there's a trend in this slide that we want to emphasize, and that trend is in green. There's a lot of different things that mature for a coordinated and safe swallow in the last 6 to 8 weeks of gestation. And so we have to be aware, particularly in our late preemies, so to speak, when we have a 36-weeker or a 35th weeker, and we may not think of them as high risk for dysphagia, and yet look at how many things are still maturing as far as the coordination in the oropharyngeal area, the upper esophageal sphincter function, and esophageal motility. And to that point, the lower esophageal sphincter, which transient relaxations of the lower esophageal sphincter will be responsible for gastroesophageal reflux disease. So what do we know about acid reflux and silent aspiration? Well, we do know that it's common, that aspiration is very common in patients that have any feeding or swallowing dysfunction. We do know that BFSS shows dysphagia, and that is how we determine this. And we do see gastroesophageal reflux in some patients, but is it causing the dysphagia, or is it an association? And that's where the evidence is very weak. There's been a lot of work done with biomarkers, looking for GI biomarkers into the BALs at aerodigestive workup. And there's also some clinical evidence showing that treating dysphagia alone without reflux therapy, and you can argue, well, what do you mean without reflux therapy? Because if you're thickening, that's reflux therapy, right? So again, going back to the weaknesses of some of the data that we have, but that is the data, okay? So the implications of this are that probably we are not going to jump and treat just the reflux. We're going to think of the dysphagia as a culprit. Okay, so you're telling us there's no standard linking between the reflux and dysphagia. You're telling us that there's a symptom overlap, and you're telling us that, yes, there are some comorbidities that can also play into this whole situation. And I'm also telling you that reflux is heterogeneous. So what gastroenterologists see as reflux may not be what you clinically see as reflux, because we're talking about the type of reflux. Is it acidic? Is it not acidic? Is it weakly acidic? Does it go all the way up? Does it stay there? Right? So there's a lot of nuances, and that's why Gerber and I butt heads all the time. But in a team, this is where you understand each other's perspective. So what do we do? How do we treat those patients? Well, there's actually a very recent study, and I want to tell you, this guy was a resident here, so we're very proud of him. He's a motilist now, so he does a lot of motility. He's a motility expert in GI. And he and his group has developed this very nice pathway that you can use in your practice. If you have an infant with feeding disturbances, check for aspiration first. Get one of your speech and language pathologist members to join in and understand what is happening when that child is feeding. If there are persistent symptoms, don't be afraid to do a 2 to 4 weeks treatment of pharmacotherapy for reflux. If it's acid reflux, which infants don't have very much of, but if it is, you will see some improvement. And if you do see improvement, 60, 70% and above, then you're probably dealing with a comorbid situation of gastroesophageal reflux. If you don't see any improvement, consider escalating to GI care, more in terms of workup. So pH impedance probe, understand what is happening and how the symptoms are correlated with the type of reflux. And that really, at that point, probably requires multidisciplinary evaluation. I want to switch gears a little bit to the inpatient setting. And this is about patients that end up admitted for malnutrition. And we're talking infants in particular in this case. I was mentioning to Vasu earlier this morning that we had a very nice presentation by the hospitalist group a couple of months ago, really very, with a research protocol that was particularly targeting those patients. And what I'm saying is there's a nuance to how we can think about those patients as well, which means that we have to understand that if a patient has malnutrition and they have any feeding concerns, they already meet criteria for PFD diagnosis. So in our in this cohort, further in Sweden, further identified, that the majority of patients that end up admitted, which is again something that we would kind of think about anyway, are probably the more severe patients. But whether they are or they're not, PFD, if they have any feeding concerns, is going to be something we need to screen for and address. So what are the clinical implications of this? Well, if we do not think about that next step, what are we going to do? Okay, they needed the NG supplementation, but what are we going to do about what caused this state of malnutrition to begin with? Then we might delay treatment. And that early identification will require then feeding intervention. Once the patient is nutritional or rehab, then maybe a multidisciplinary effort to understand what are the barriers to eating as the next step. So how can we identify, to the point of your learning goals, how can we diagnose PFD? How can we screen for PFD if I'm a PCP or if I'm a hospitalist or even a subspecialist that sees those kids in their office? Where the tools that are here in the pink box have been validated, and a questionnaire, a 10-question questionnaire can be used in your screening pre-visit, or you can do it as you're getting your history inpatient. Those are some very important questions. Does your child, very specific, do they refuse to eat or drink? The specific encouragement is going to be high stress for the family because this is all they do all day, to try to get the kid to eat, right? Are the meals prolonged because the kid is running around or because they don't want to eat, and now we're sitting at the table for an hour and a half? Have they had difficulty gaining weight? Are there aerodigestive symptoms like cough, gag, choke? Are they avoiding any particular food groups altogether, what we call selective eating, or textures for that matter? Is there high level of parental stress at the meal times? Obviously, if they have a tube, that's already a point. Is the child distressed just at the sight or at the taste or at the smell of food? So those are kids who may be gagging and choking just being in the kitchen. Do they have any GI symptoms? And do parents see any problems with the mechanism of chewing and eating? So there's a lot of references here in the slides for you to realize that that you can use this. There's evidence for it. If you have 2 or more positive responses on this questionnaire, that's a positive screen. What do you do about it? We're going to tell you in a minute. But that really brings us to the breakthrough in defining PFD. And that happened in 2019 when an international consensus established the first unified definition of pediatric feeding disorder, recognizing it as a disorder of eating and feeding. And this consensus bridged medical, nutritional, behavioral disciplines, transforming the diagnosis, research, and care coordination that happened since then. Now, I do want to say that our group has done this work for about 7 years. Prior to that, we just didn't have a diagnosis. We didn't have an ICD-10 code, and it was much harder to get it through as a process through the system. But certainly, we welcome this. Now, how about the prevalence? So the prevalence is up there. That's most updated incidence, But the prevalence was also studied in retrospective cohorts from Arizona, Wisconsin Medicaid, as well as an insurance database, private insurance database. And the annual prevalence is anywhere between 2.5 and 4.3%. The prevalence is higher in patients that have any other medical conditions or aerodigestive patients. So patients that have GI and respiratory symptoms or complex congenital or additional medical problems. And then if you look in this aerodigestive cohort, about 100% of the patients with aerodigestive symptoms have at least 3 criteria met for PFD. So high prevalence in that particular population. I want to spend 1 second on oral aversion, which is a very powerful PFD symptom. It tends to be much more prevalent if you have any kind of medical condition and if you've had any kind of medical interventions in infancy. If you look in patients with esophageal atresia, for example, the incidence of oral aversion in that PFD is very, very high, about 60%. Aerodigestive patients in general might have had airway or GI interventions around the oral pharynx, so that's another high-risk population. And then about 10% of infants that are premature may have oral aversion as well. And the reason we even want to talk about that as it's one of the harder PFD to treat, because it takes a long time. And it takes a lot of education. It takes therapies. It takes a team. That's probably the ultimate multidisciplinary situation to consider. Those therapies involve desensitization, sensory integration, messy play, a lot of things that parents look at and they don't understand, how is this going to get my child to eat? And yet that is a very important pathway. Now, programs around the country, including ours, have used other techniques to treat oral aversion, including tube feed weaning, treatment of underlying medical conditions such as EOE or esophageal dysfunction or gastroparesis. But it usually takes a multidisciplinary approach, because whatever the influences of the past or the active medical conditions influence the fear about eating. Behavioral therapy, Dr. Hodges will talk a little bit about that. I just wanted to put up there, you might be familiar with pharmacotherapy that changes appetite We've used cyproheptadine very safely in our program. We sometimes in older kids have to consider disorders of gut-brain interaction, including chronic pain, chronic nausea, as being factors, barriers to eating. So treatment of that is very important. And then there's, I thought that was a very interesting piece of information that I didn't know about. There's actually a pharmacotherapy, D-cycloserine, that in combination with behavioral therapy can be used in very significant cases of oral aversion. And early dysphagia treatment is really the key in the patients that have it. And the protocols that can change the natural history of that persistent or dysphagia and aspiration, particularly in young patients, is key. And I just wanted to emphasize that North American Society of Pediatric GI and Nutrition remains a leader, very interested in this field. 2 words about what an intensive structure or model of treatment can do in patients that are ready to come off, but they're kind of lingering through the system, getting some therapies in sort of that therapy domain, and some treatments in their GI domain, but nobody is actually able to determine if they're ready for a wean, because if you're in the office, you don't know the skills. If they're in the SLP office, they don't know the medical, and then, you know, things get prolonged. So what we did, we looked at young children, and we started work in our intensive program, which involves all of those domains all together. And then we compared those patients with a group of patients who just went through traditional therapy model, once a week, once every other week, and then their GI visits every 3 to 6 months. And we noticed that our program is 5 weeks, and they get therapies every day, at least it was at the time. And what we noticed is that the patients in red, which are the intensive patients, reduce their dependence on G-tube, NG, or liquid nutrition quite significantly, whereas the other ones may reduce it a little bit, but that 25 visits is already, sometimes it was 6 to 9 months, right? And then if you look at the traditional model, it would take the patient an estimated 3 years to wean off just by, you know, kind of staying in that maintenance of care situation. And those outcomes were also holding on at 1 year, particularly what we call tier 1, 2, 3, which are the patients that have skills already and they're building a lot of endurance. They tended to stay off or have their tubes removed, whereas the tier 4, where we're building the foundation of skill and we haven't done a lot of, we're not targeting enteral nutrition reduction because they're not ready. And so more work to be done in this, you know, long-term category. I wanted to emphasize that there are medical conditions that can cause PFD and others that are commonly associated with PFD. The causation are going to be mucosal disease for GI, perinatal risk factors, anatomical abnormalities, and cardiac disease as the biggest categories. And when it comes to conditions that are commonly comorbid, don't forget about, I mean, we're all very familiar with our patients with developmental disorders of all kinds. The interesting one to remember is chronic respiratory disease can be associated, a big factor of comorbidity for PFD. And lastly, our group, our fellow who graduated last year, Gerlin Calon, is publishing this, showing that there is more to be understood about PFD and the functionality of the esophagus in PFD. And with a new technology called EndoFlip, which is really a modality to check the esophageal contractility, diameter, and distensibility in very young patients under anesthesia. The UES, so upper esophageal sphincter dysfunction with a restriction to relaxation, was present in 30% of our patients. So what is the natural history of that? how do we manage it? There's a lot of different things going on right now in our group trying to define treatment in those patients. So with that, I'm going to pass it to Dr. Hodges to discuss the psychology role in PFD.
Thank you, Dr. Williams. And I'm not just saying this, but every time I work with a team, I'm learning something new from speech, from OT, from Dr. Williams, from nutrition. So it's been a very, very cool experience to establish this role in PFD. And today I want to tell you kind of about what psychology's role in assessing for pediatric feeding disorder or just kind of general feeding difficulties, and then how primary care physicians can utilize these considerations when patients present at their appointments, because a lot of times pediatricians, you're the first stop that kiddos are coming to. And so having some kind of basic strategies and then knowing where to refer and when to refer can be super helpful. I have no disclosures. To orient us just in general, I think it's really important to understand what the biopsychosocial model is and how behavioral health providers use this framework to really conceptualize presenting problems just in general. These three domains, biological, psychological, and social, really work together to paint a comprehensive experience of what the patient's experience is. For biological, and you all are very familiar, their personal medical history, their complex medical history, what's their current health status. I think it's really important too, are they currently in pain or feeling discomfort? That can affect a lot of social interactions and kind of psychological well-being. Are they currently taking medication, and are there negative side effects to that medication? What's genetic predisposition, and what does family medical history look like? Because that can kind of set the stage for when you have suspicions for things, exploring further. The social domain, what is the child's family system, both immediate family and extended family? Who's involved in that kiddo's life? What's their school experience like? Are they in person or online and at home? And I think that distinction has become very important post-COVID. It just kind of gives you an idea of their opportunities for peer socialization, just extracurricular activities too, which can really help in maturity and development. Cultural factors. So what cultural attitudes or values affect behaviors? And I think this has become a focus in the medical community in recent years, and importance cannot be overstated for keeping those considerations in mind, because it can really alter the treatment trajectory. Systemic inequalities. So what has the patient's family, what has the patient's experience been with the healthcare system? Have they felt like they've been heard and treated well by primary care providers, from specialists, from mental health providers, or do they feel like their concerns just have not been addressed and they're approaching healthcare with a bit of wariness? Sources of stress. So whether that's family stress, financial concerns, death or illness in the family, or are they getting bullied at school? That can be a huge factor in the psychological well-being of a kiddo. Finally, moving to individual psychological factors. So do they have any mental health comorbidities, or are there concerns for that? So this could be ADHD, trauma, anxiety, depression, kind of you name it. Are you looking for that? Diversity factors, gender, race, socioeconomic status, development. Are we looking at any possible delays in speech, motor, cognitive development? Sleep, which is a personal favorite of mine to look into. And I think it can not be overstated how important this can be in a kiddo's life. Do they have a good, consistent bedtime routine? Do they have trouble falling asleep? Are they waking up throughout the night? What's their energy? Because if they are not getting good quality sleep, we are not setting up a good day for them. And their emotional reserves are just lower before they've even started the day. What's their temperament? Are they active kiddos? Are they fussy kiddos? Are they kind of all over the map and unpredictable? Or are they calm, cool, collected? Coping skills. Can the patient self-soothe and regulate themselves, or are they dependent on parent? And the co-regulation we'll go into, that can be crucial, because Kiddo gets ramped up, parent gets ramped up, kiddo gets ramped up, and all of a sudden we've just kind of hit an explosive point and it's hard to bring themselves back down. So now that we understand this general framework for how behavioral health is looked at, let's apply these domains to pediatric feeding disorders. And I really want to pay special attention to the social and psychological domains. So for my job, I'm looking at the home environment. Who's involved in feeding? What does the day-to-day look like? What's their feeding schedule? Sometimes parents are really consistent in meals and snacks. Other times there's kind of this open door policy where the kiddo is praising. And it makes total sense. Parents just want their kids to eat. So they're opening the door, whatever you want, go in the pantry and get it. But we'll see how that can be problematic as we continue. Behaviors, refusal behaviors, both feeding and non-feeding related. So non-feeding refusals can look like a lot of different things. Sometimes kiddos just simply aren't interested. They push away, no thanks, we're turning away. Other times behaviors can get aggressive. Are they hitting, biting other people? Are they injuring themselves? Sometimes in kiddos in high chairs, we see them throw their heads back a lot, and that's their cue that they are just done with feeding. I think it's really important to highlight that feeding behaviors rarely occur in a vacuum. Parents are seeing this dysregulation in other contexts, whether it's at home, whether it's peers, whether it's school. And just targeting feeding might not get you where you need to go. So part of my job is really just parent training, behavioral regulation in general. Temperament, again, we've talked about the fussy kiddos, which feeding just becomes a real challenge. The active kiddos who cannot stay seated to save their life. The chill kiddos who just aren't interested in feeding and you're really just trying to ramp up that interest. Again, sleep. So are they going to sleep late? Are they getting snacks late at night? Because then maybe they're not hungry in the morning. Are they waking up for feeds in the middle of the night? That can really disrupt the quality of sleep. And again, poor sleep can really affect energy the next day, and their behavioral regulation ability is already low. So good luck presenting them with feeding multiple times a day. The parent-child relationship. Feeding can become incredibly stressful for everyone involved. We've talked about that co-regulation aspect. Parents understandably get frustrated with themselves. They blame themselves. They're getting frustrated with their kiddos. It's really difficult for parents to understand, or those of us who haven't had feeding difficulties to this degree, it's difficult to understand why kids don't eat, why they're not moving faster down the developmental pipeline. And we take for granted just the sheer number of steps there are between being presented with food and actually chewing, swallowing, consuming food. So those steps can go painfully slowly, and it's really helping parents understand that let's make this a positive experience. We kind of need to read kiddos' cues and go at their speed. Inter-parent conflict, you will see this in evaluation. Parents can disagree. Their approaches can be wildly different. We often have moms or dads come in, and one parent who's heavily involved in the feeding will be stressed. They're kind of in the trenches for every meal, every snack, and they're just getting, it's a tense situation, and feeding is dreaded. The parent who maybe is not as involved is like, they're gonna grow out of it, they'll be fine, we're kind of freaking out over nothing. And so you're really trying to take both of those into consideration and align parents on goals and approaches. Some parents set stricter limits, and short term that might help the kiddo feed, but over time that feeding just becomes a negative experience. Some parents are more removed, and just whatever the kiddo wants, the kiddo's gonna get. Comorbid mental health diagnoses. So I think, correct me if I'm wrong, but I think some of the most common ones we see or have concerns for are ADHD. If they can't stay attuned to feeding, or they're just always on the go, they can't stay at the table long. And so you're constantly having to redirect them back. And after 2 or 3 times being redirected back, they just don't want to eat anymore. We have quite a few kiddos come in with concerns for autism spectrum disorder. That can really look like sensory challenges where the sight, smell, texture of food is just, it makes feeding really difficult. There's kind of repetitive behaviors or engagement with parents during feeding, which isn't really there. Anxiety. See kiddos who have choked on something in the past, or they've had EOE and they've got a very limited repertoire of food they'll accept because they're safe foods. And now they're 8 years old on a PPI, and we're really trying to expand that palette, but you're trying to undo then 8 years of anxiety with foods. Other stressors, if family has limited resources, getting different types of foods can be really difficult. So screening for kind of food safety and access. If there's kind of family stressors like death, illness in another, how much attention can really be paid to feed, or how much attention can be paid to feeding, and are we triaging kind of all of the different stressors that are going on, and where does feeding fit on that pyramid? Cultural practices and values. And I think as a team, we're really starting to pay good attention to this. So what do their diets look like? Are there any cultural practices where it would affect feeding time or the types of foods that are offered? So then that gives us a cue during feeding sessions. Our suggestions are a blueprint, but we really need to follow what's going to be sustainable and realistic for the family. What does the culture say about feeding milestones, breastfeeding, degree of parent involvement? We've seen some parents have a heavier hand in feeding. There's kind of borderline force feeding going on. And again, it's short-term, get you what you want. Long-term feeding is incredibly aversive. Some parents are a little more lax and pulled back, and trying to put the reins and control that can be challenging. So now that we understand how psychosocial factors affect pediatric feeding disorder, here are some strategic and very concrete ways pediatricians, primary care providers can utilize this in that first appointment. So I understand, and we all got it. You're crunched for time in these appointments. So this might not all be doable, but kind of going through, get what you can. A comprehensive picture of patients' current feeding and past feeding history. So the who, what, when, where, why of things, the refusal behaviors. And whoever said observing the kid eating in their appointment, genius. Like if you can see that, do it. You will see what refusal behaviors look like. Are they walking around the room? Are they throwing the food? Are they crying? Are they in discomfort? Developmental and mental health concerns. So again, we're not expecting like a full battery of anything, but again, in session, are you seeing behaviors that are of concern, or kind of set your radar off that further assessment with a behavioral health provider, psychiatrist, psychologist would be helpful. Parent expectations. So when parents come in, and we've seen this in feeding, kiddo is 100% tube dependent. And in our intensive program, they're with us in that intensive phase for 6 weeks before they transition to kind of less frequent. In that 6 weeks, parents are expecting from 100% down to 30%. And that is a very, very tall order for kids. Each kiddo goes at their own pace, but parents understanding that, really just setting the stage and teeing them up for, if you do make that referral, it's kind of already there of, we are going to set a realistic goal. And if the kiddo zooms past that, fantastic. But let's really start to follow the kiddo's cue in, with some guardrails on it. If appropriate, and this is for our older kiddos and can be super helpful, the patient's point of view and their understanding. So some kiddos are scared to eat, and they'll say, because I don't want my stomach to hurt. We see this with a lot of kind of the gastroparesis, constipation, motility concern kiddos. Some it's anxiety. I choked, I don't want to choke. Other kids, it's that sensory, I can't even look at it on my plate because it's disgusting. So really, if you can, if they're old enough and developmentally it's appropriate, trying to ascertain what prevents them from eating. Education for families. So this could be just really basic. consistency, consistency, consistency. Set that routine, set that structure, get parents in agreement, and make sure you're presenting feeding options. But when it gets to the point where you can tell this is going to be a battle, call it. Don't try to continually push it just to get food in their system. You'll have other opportunities throughout the day. Helpful language for the families. And I think this is going to be crucial because families may come in already feeling like their concerns have been minimized. So sometimes they've been told by well-meaning providers, family members, friends, people on Facebook groups, if your child is hungry enough, they'll eat. We know that that's not always the case. Kiddos' hunger cues and satiety cues are just dysregulated, especially if they've had feeding concerns for a long time. So you can try to wait meals and skip meals. They might not respond to it. And so that's where appetite stimulants can come in, structured eating comes in. Another one is a kiddo is going to grow out of it. We've seen this is often not the case either. And then they get to be, 8, 9, 10, adolescents, and we've now got 10 years to kind of undo because the problem has just gotten worse over time. It's also really important to recognize that parents are doing the absolute best that they can. Parents will come in and they're ashamed to say, we go through the McDonald's drive-thru every day to get chicken nuggets because that is one of the 3 foods that they will eat. And they are embarrassed to say that. And just understanding if you just want your child to eat, this makes total sense. It's our job to start to improve that variety and volume. So just understanding where the parents are at and that this is incredibly stressful for them. So they're doing everything that they can. Some basic behavioral strategies. And again, this doesn't need to be intensive. You just kind of need to tee it up for when you do refer out. Mealtime consistency and structure and avoiding force feeding. We've seen some kiddos come in and parents, again, well-meaning, but they're putting their hands on top of kids' hands on the high chair to prevent them from having the food put in their mouth. Might, again, help you short-term, but long-term, the kiddo hates feeding and the high chair just becomes extremely, extremely aversive. When to refer to psychology. Whenever you have standalone mental health concerns or you think behaviors are the main driver of what's keeping feeding challenges ongoing. So skill is not an issue. If they've got a medical condition, it's well managed. Sensory, there's not like a huge concern there. Refer to psychology. That's what we're here for. And if we think, hey, this is a much more complex picture, then we'll get everyone involved that we need to get involved. I think we are pretty good as a team at when a kiddo needs an evaluation from all of us, we'll take them as long as like they're in a spot where we can actually make some moves. Regardless, if you want to send them, we'll come up with a treatment plan, even if it's not through us, where we're going to set the kiddo up to really improve their feeding. That's all I've got. So thank you.
All right. So for sake of time, I'm going to kind of go through this a little quicker. So I'm here to talk about the Pediatric Feeding Disorders Clinic, which is our multidisciplinary clinic. I do not have any disclosures. So our team is comprised of experts in PFD. So as Dr. Williams talked, there's 4 domains, and I'll talk a little bit more about that, but we have a GI doctor, we have a registered dietitian, a speech therapist, occupational therapy, and psychologist, Rosie. We also have an administrative team who helps us with program coordination. Who we serve. So as Dr. Williams explained, we serve children with pediatric feeding disorders specifically. And our team partners with these families to help our children progress in eating by mouth. So that's really our goal, is to help these children move forward with eating. Again, for sake of time, I do think that Dr. Williams covered this very well of what pediatric feeding disorder encompasses. What I really want to talk about is our model. So we, again, have representation from those 4 domains: medical, nutrition, skills development, and psychology. And that's really our advantage as a program. So our evaluations begin with representation from each of these specialists in all of these areas. And we really look at the child and say, okay, how much of this is medical that we think is contributing? How much do we think is, their diet and their intake and their tube feeding? What are their skills and development like? What's their sensory processing like? And then again, as Rosie explained, that psychosocial domain. So really looking at the family and the dynamic, the child, and who they are and what that brings. At the center of all this is our child and the family goals. So we really center it around what does the family want to accomplish and what are they hoping to achieve from this evaluation. We can have many different treatment plans that come from this that can include medical workup, diagnostic procedures, management of their tube feeds. But the areas that I really want to highlight include feeding therapy, so referrals to feeding therapy, group feeding therapy where they're matched with peers in order to facilitate eating, and then our intensive feeding program. A hot topic as of lately has been ARFID, and I do just want to emphasize that we are a pediatric feeding disorder program and not an ARFID program. ARFID does fall into eating disorders. We're experts in navigating that overlap, but if we do identify ARFID, we will refer to eating disorders specialists here at PCH or in the community. All right. So our intensive feeding program, so it follows a very similar model to our evaluation process. Again, we have representations in all 4 major domains of PFD while keeping the patient and their family at the center of all that we do. What we really have an advantage of, again, is we can monitor these progress in live time and talk as a team. You know, is one impact in one area affecting the other? What do we want to make adjustments? Do we want to add cyproheptadine to drive hunger? How does that affect the child behaviorally? Does it impact their sleep, their behavior? Are they having the oral skills to sustain the diet that they need to be eating? And do we need to modify textures? So again, really a comprehensive treatment plan, looking at all different areas and really encompassing the whole picture of the child while encouraging that parent to participate and become a trusted mealtime partner for their child and learn these skills to take home. How our intensive feeding therapy program is structured is, again, it is more frequent. So some of that intensity is also the frequency. They are seen 4 days a week for the first initial 6 weeks of that program with weekly or almost weekly GI and nutrition along with psychology support. They then transition to what we call the transition phase, which is the remaining 6 weeks of that program where they're seen less frequently, so twice a week and then down to once a week. And they have follow-up with GI and nutrition at a 2-month mark and a 6-month mark. And then we also do what we call a maintenance phase, which is kind of determined case-by-case basis on how they made progress. And again, thinking about the ideal candidate for this, really what we have an advantage of is a really controlled environment. You know, where else are you weaning down on tube feeds, but you have support from all of the professionals necessary? If you have a child that you're like, I'm not sure that they could do this without the adequate support, that's the child that we really want to see. So I put down some general criteria as far as age range goes. But really thinking about this question can be a little bit complex as our patients have many faces. You know, they can be a 12-month-old who's weaning from their tube, but they could also be a 10-year-old who has Down syndrome and has only eaten purees for the rest of his life. We've seen good success with those patients as well. You know, they could be a selective eater and they're adding foods to their diet and they need that support from occupational therapy to help regulate to come to the table. And they need that cyproheptadine to get that appetite going. So again, you know, I want you to kind of think about these criteria, but also remember that the child with PFD looks very, very different across the board. I do see a question.
That they need to have at least 85% of their ideal body weight. Is that strict cutoff? Is that a big target? Because I know a lot of these malnutrition. Where do you draw that line?
Yeah, so that kind of comes from, we don't want to see them in, you know, moderate to severe, because that does obviously require then maybe we want to intervene first from the nutritional aspect and then consider intensive therapy, just because if they're already in that state and we're considering making more extreme or more aggressive interventions, that might not be appropriate. Does that kind of help and make sense? Again, think of these criteria as kind of loose. All right, program outcomes. So we are a program that's over 15 years old. We serve at 3 different locations across the valley: Avondale, our Thomas location, and then Mercy Gilbert. And we are the only intensive program led by a physician in the state of Arizona. And I think that brings a great advantage to us as well as expertise. Our results are strong. So we see great reduction in enteral feeding with children with complex medical conditions. This can also result in long-term healthcare saving costs. And our current wait times are between 1 to 2 months. As far as future directions go, and this is kind of the drive home point, Again, we see this prevalence of 1 in 37 children, and there's a high prevalence of problematic feeding amongst children who are born at 37 weeks or less. And so what we really want to focus on is PCH, and our healthcare system really is positioned as a leader in this field. We possess the teams, the multidisciplinary teams, the experts to be seeing these kids, and these kids are coming through. So we really have an opportunity to drive innovation in this care. Just some areas of opportunity for development, including early referral to therapies. So please make sure to be referring to therapies when you're identifying these signs, as Dr. Williams said. Partnering with some of our key stakeholders. So we know that our multidisciplinary clinics are seeing high volumes of these kids that are most at risk. So if that is somewhere that you end up one day, knowing to look for the signs of PFD and when to refer. And then facilitated improved management of, again, those discharges from inpatient or the NICU. What's their next steps? What does that pathway look like? And I'm going to leave you with this, why it matters. So I really just want to emphasize and thank you guys for being here today, because by being here today, you're inherently helping us with our goal of achieving awareness for PFD in the community and referral to, again, appropriate treatment. It's our hope that after today, if a parent tells you, I'm concerned about my child's eating, it's really difficult to feed my child, I don't know what to do, that you continue to be curious, ask those questions, make the appropriate referrals. Because we know that it's not just something they'll grow out of, and it takes a team. And we're really grateful for the involvement that each one of you has in our patients' care. Okay.
Just one question, it's a yes or no question. Can you refer directly to this program, or do you have to go through GI?
You take the question. I'm so sorry, or do you have to
Okay.
go?
Can an outpatient pediatrician refer directly to the pediatric feeding disorder or referral to GI?
You can now refer as a pediatrician. So what happens in that process is we will review medical records as appropriate, and then determine whether or not they need to see GI first, or if we feel like they can directly be seen by our program. So that is new, actually. So I appreciate that question, because previously we did require being seen by GI within our practice. So thank you.
We need to get the residents back to the board. Anybody else can come forward and ask questions?
Please vote on your way out.
I was watching it, I was like,
GI fellows is a must.